Now is the time when we're going to talk about AI and COVID. To share the impact AI has had on COVID and the implications for enterprises, we have Romy Hussain. Romy leads the centralized AI program for Johns Hopkins, and her work has been instrumental in helping their system treat COVID patients and in helping the state of Maryland respond appropriately to the pandemic. Romy's perspective is an interesting one, filled with hope for the benefit of AI in responding to a catastrophe, but also with caution due to policymakers' less than data-driven decision-making approach. Please welcome Romy to the virtual stage.
Thanks so much for your warm welcome, and it's such a pleasure to be here again with you at AI4. Thanks for being here. I wanted to come to talk to you guys today about the ways in which AI can support enterprise-level projections, enhance operational optimization, both in the healthcare industry and beyond, and help prevent future infectious disease outbreaks. As a little bit of background, I lead a team at Johns Hopkins that's responsible for providing decision intelligence support for Hopkins executive leadership. In other words, helping our executive team make better decisions using the right analytical tool for the job at hand with the data that we have available to us. Sometimes it's a hard job, sometimes it's next to impossible. What I've learned, however, particularly in the course of the pandemic, is that data-driven decision-making can push organizations to make better decisions that are replicable, low in variance in terms of the quality of their outcomes, and scalable in ways that we simply couldn't do by relying on our personal decision-making heuristics alone. There are three primary vectors of decision-making intelligence and support offered by AI: prediction, optimization, and prevention. There are others, but these are the ones I want to focus on today. Now, these benefits can be tapped into by policymakers and corporations alike. In fact, in the absence of a coordinated, widespread national response, they absolutely should be tapped into to ensure that responses are rooted in local realities and the science driving them. Much like the data science community itself, which is based on principles of open source transparency and shared best practice, I'll be using models from around the world during this talk. Not only the models that my team and I have created ourselves. In a fast-moving, ever-changing environment, like the one that COVID-19 puts us into, it's imperative that we learn from as many examples as we have available to us and share our learning in turn so that as many lives as possible can be saved in the process. On that note, the first and perhaps most critical AI vector is prediction. AI has the ability to answer critical questions about the next stage of the pandemic, what its impact is likely to be on both individuals and populations within an organization's purview. At Hopkins, for example, we model impacts around our patient populations. However, we've also completed similar models for state governments, even multinational corporations, to help them assess some of their own risk factors and develop their internal levels of risk tolerance so that they can gain the insight they need to make the best possible decisions for their own constituents. Two key model types emerged during the course of the pandemic and proved to have exceptional usefulness in predicting pandemic phases and the interaction of various events. One's old, based on the traditional epidemiological math. On the left, you see the SEIRD, SEERD models. One's really new, or surprisingly new, in the corporate decision intelligence space, and it belongs to a growing, exciting branch of decision science called multi-agent systems. That's the one that you see on the right. Now, the SEERD model has lots of different flavors. It's the interplay over time, the exchange between various disease states. People can go from susceptible to exposed to infected to recovered, presumed immune, and then deceased. Different infectious diseases use different states to model them out. So the common cold, for example, you would only go from susceptible to infected, then back to susceptible. For COVID-19, we actually need all 5 states to appropriately model the pandemic's flow. Agent-based modeling, the one on the right, however, uses individual agents whose rule-based behavior can take many forms. Agents can interact collaboratively, competitively, even adversarially. We'll talk more about these systems later. For now, suffice it to say that the SEERD models are really useful for absolute and accurate predictions, whereas agent-based models are better for predicting multiple scenarios involving groups of individuals or pods to identify the relativity of results under different operating scenarios. Predicting how the disease will spread based on gradual reopening of society can help policymakers to understand what effects their decisions could have on complex social webs of individuals. This is where those multi-agent systems really shine. By putting these two types of models together, we're actually able to accomplish a lot. We could start to predict the rate of transmission based on real-time data, see how it affected various types of patients, for example, those with pre-existing conditions or exacerbating comorbidities, and then seek to understand the thread within different types of communities, for example, urban versus rural. We could also start to test out, using that agent-based sim, what the impact of various policies might be. What would happen if a county or a state decides to shut its borders or mandate lockdowns? However, in the enterprise state, to be truly useful, we needed to test another type of potentiality, the economic one. Hospitals, payers, device companies, pharma companies all experienced wildly different impacts of this pandemic. That's just the healthcare industry. Many hospitals, for example, were bled essentially dry financially, while payers exhibited a windfall. So outside of healthcare more generally, there were real questions when it came to return to work safety and how that balanced out against financial concerns. Restaurants in the hospitality industry, for example, were impacted perhaps the most existentially. For them, knowing when normal operations could safely resume and at what capacity was critical to decision makers as they attempted to navigate both the public health and the economic landscape. For restaurants in particular, the difference between opening a month early at 25% capacity or delaying another month from reopening at 50% capacity can be a huge difference. It could be make or break from a cash flow perspective. This is where those agent-based simulations, again, really come to the fore. We can start to get an idea of how likely different scenarios are to actually occur. As wonderful as all these models are, and they are pretty fantastic, there's not one in existence that describes reality perfectly, not one. Turns out that the wisdom of crowds actually applies to models as well. The CDC took an ensemble approach by merging dozens of different models to derive their own projections. So when you hear CDC forecasts, it's actually a basket of models taken together that are compiled to form surprisingly robust predictions. If you look really closely on the left-hand side of the screen here, you might see a tiny little green line. That's actually the Hopkins model. You can see that there's an incredibly wide variance, however, in the predicted confidence intervals of all these models. But astoundingly, when taken together, they tend to describe the actual with remarkable consistency. Ensemble approaches in machine learning in general tend to yield superior results, especially in volatile environments with a lot of unknowns. And this instance was no different. On the right, you can see the composite model that actually has a pretty tight confidence boundary around it. And when I say tight, I mean that it's centered around the actual results of the pandemic. So that's a highly predictive and relatively robust result. I contrast this to the White House coronavirus task force briefings, which relied on a single model alone, and one which, at that, wasn't initially rooted in scientific precedent per se. It was incredibly difficult for the country to make good decisions based on that single model that had a large error variance bouncing around day by day. Sometimes it was, twice what it was the day before. Instead, taking the data science route and blending many forecasts was both more stable and secure over time. There are a lot of reasons that we would want to get the disease predictions themselves right. However, prediction isn't terribly useful if it's in a vacuum, and if it doesn't inspire the right actions on the part of the enterprise, which leads me to the next point, operational optimization. Given we're in a pandemic, resource utilization will not be what it was in the BC era before COVID. Resources can be a lot of things here. For a hospital, it's intensive care beds, med beds, probably ventilators, for a city or county, analyzing hospital resources at the level of granularity at which the decision must be made is critical. We saw clearly how some hospitals were relatively untouched by the pandemic, particularly those in wealthier areas. Their counterparts, however, often sometimes just a couple miles down the street, were inundated. Load balancing within a county, within a state, became critical to keeping the curve as flat as it could reasonably be. For the enterprise, maximizing resource utilization in many cases meant pivoting to new ways of doing business, much of it remote, and ensuring that those team members who did need to remain on-prem were protected up to the risk tolerance thresholds of that particular organization. In the healthcare space in particular, we had a chance, an opportunity to devise new ways of thinking about old problems really fast. The ER throughput optimization model is something that sort of every entry-level MBA does in their first year. It's kind of the, crowning glory of resource utilization optimization. What we saw, however, went way beyond, transcended those B-school basics into something far graver. But by blending linear optimizations of variables like bed use and provider availability with those agent-based systems that modeled out how patients with certain characteristics were likely to respond to various treatment types, we were able to get closer to a data-driven prioritization protocol that used the hospital's actual operational position at that point in time with modeled scenarios of patient prognosis. Many of us heard about the tough choices that some clinicians faced and were forced to make, especially early on, in which they had to make snap judgments about, for example, which patients to put on a ventilator, which patients to give life-saving antiviral medications to, which ones to discharge or keep under observation. Mistakes were almost certainly made, not because of human fallibility per se, but also because of a lack of a complete data set at any one node in the global healthcare web. One thing machines are actually pretty good at is parsing large data sets for subtle signals that we sometimes miss or simply can't access. So by sharing data sets widely, across state, even national lines, many healthcare organizations were able to streamline their delivery operations, and some even adopted protocols like ours to support clinical diagnostics in real time. This is that part about the multi-agent systems that I promised earlier. Agent-based modeling is, again, relatively new in the corporate decision intelligence space. We model complex systems composed of individual actors or agents whose behavior is described using pretty simple rules. These rules can correspond to spatial patterns, where people live, where they work, social characteristics like the social determinants of health, health conditions, what their underlying comorbidities might be, and infection fundamentals under which the agents are interacting to characterize either the transmission process or a treatment process or some sort of policy intervention. So you can use them to do lots of different things. Take the Imperial College London agent-based system as an example. That's what you see here. It rose to prominence early on, bolstered both by the accuracy of its predictions, as well as the range of scenario modeling that it was capable of. Factors model included ones which aren't necessarily captured by traditional epidemiological models, those seared models that we talked about earlier. Those edge cases turned out to be definitional to this pandemic. Think about the asymptomatic carriers or people who ended up testing falsely negative, but then ended up being super spreaders within their community. ICL modeled out a number of policy interventions and then studied how the virus would ebb and flow with each. So here we see home isolation of cases. People with symptoms of the disease are kept home for 7 days, regardless of whether they test positive or not, home quarantine. We see social distancing. We see social distancing of only folks, elderly folks, people over the age of 70, or downright closures of schools and universities. You can really see in the ebbs and flows, the sort of peaks and troughs of this chart, the aggregated simulations playing out. That's imperative information to decision makers who need to decide which one or two or three of these policies to roll out at any given point in time. Here is a diagram of a return to work decision model that actually was created at Hopkins. The 5 steps work together seamlessly to help inform organizations what the earliest, midpoint, and latest possible safe return dates might be for a given risk threshold. This part's really important. Some organizations might decide that any risk is too much, while some may feel that a calculated, closely monitored risk, particularly if they fall outside of a hotspot, is a reasonable risk to take. Again, this is going to vary really widely by industry. Hospitality, retail, healthcare, consumer goods will tend to err on the more risk-taking side here, simply because those organizations cannot function without on-prem staff, whereas most professional services organizations, for example, will almost certainly opt for alternate arrangements in which the risk of uncontrolled indoor spread among office workers can be mitigated. Now, once we know what's likely to occur from the prediction step, and we know how to optimize for our risk tolerance with the resources that we have available to us from the optimization step, it comes time to implement measures to consolidate the progress we've made and to prevent future outbreaks. We see pretty clear call and response type dynamics between the times in which restrictions are imposed and the times when they're lifted. Take, for example, the red spots here are the lockdowns. The green spots on this upper chart are when lockdowns are lifted. You can see when the lifting happens, there is a gradual uptick in infectious disease spread. That might be a reasonable risk that, in this case, the state of Maryland is willing to take. But we also see the behavioral impact of times when society deemed it maybe less necessary to maintain social distancing protocols. This is primarily around holidays. Take a look here in July. We're at a low, but then you start to see this creep back up. You start to see the spike that's likely due to social laxity around the summer holidays. We actually never got that number all the way back down to the average of July. And now we're starting to see even more uncontrolled transmission as we go into the winter holidays. The slope doesn't look like it's going to let up anytime soon, barring some pretty drastic measures like closed borders, mandatory masking, mandatory lockdowns. So the cause and effect of behavior on the transmission rate really can't be denied. One preventative tool that many organizations have now adopted is a symptom screener app for employees or even customers who are located on premise. Some, however, are taking this idea a step further by injecting some predictive power into the process, such as by triaging the organization's location with the local projections and an employee's individual risk factors. This is another model that came out of my team. I have to say, it's a little easier when you work in the healthcare industry and have access to things like clinical records, the world's best COVID tracking data. However, a modified version of this could likely be implemented at nearly any organization with enough willpower and really strong data governance around things like PHI. If implemented widely, systems like these can serve not only as individual decision support, should I go to the office today, but it also serves a tracking and tracing purpose that can start to inform predictive models even before positive tests start to register. We saw in many places that flu-like symptoms increased suddenly about a week before the first positive cases started arriving in the hospital. If we could contain an outbreak at its source, it goes a long way toward preventing the next one. There are almost too many use cases of AI in the healthcare industry to go into all of them. Let's just say that COVID has fundamentally changed the way that we measure the outcomes associated with healthcare, as well as the fundamental processes surrounding basic functions of the healthcare industry. AI is an amplifier, and it's made it clear that there's no great reason not to use advanced computation techniques to accelerate basic tasks like parsing patient records or real-world evidence. These are signals we might once have missed. Another piece of the puzzle is this. Healthcare experienced a once-in-a-lifetime black swan event. Patients weren't admitted or weren't operated on who would otherwise have been operated on in order to make room in the hospital for COVID patients. Those patients didn't sit at home patiently, no pun intended. Many of them exacerbated. They got worse over time, and then they ended up right back in the hospital, this time in the ER. We must learn the patterns from this incredibly unusual time when many providers took actions that they wouldn't normally have taken, so that we can try to care for as many patients as possible with the right course of action. Reinforcement learning, which is do this, not that modeling, is a fascinating frontier here that my team and I are working furiously on, precisely so that we can start to help clinicians determine the best course of action for any given patient, even under suboptimal delivery conditions. This is truly the frontier of individualized care. When all is said and done, the bright spot that I'm taking away from the pandemic is the power of cooperation. From breakneck speed vaccine development to vast networks of data science teams sharing models, code, data sets, shared practices, to clinicians the world over pooling new information and observations daily to try to collectively learn and study this virus even as they were fighting it. What has become evident is that together, using the best tools available to each one of us individually, we have a shot at overcoming. Thank you so much. Would love to hear any questions that you guys have. Peace and masks.
Thank you for sharing your insights with us, Romy.